So, good afternoon, everybody. I'm sure more will be coming in the coming minutes, but I'd like to welcome you to today's information session webinar. My name is Stephen, and I am the Communications and Membership Officer here at Mental Health Reform. Thank you for taking the time to be here, for taking your lunch. We know how important this topic is, not just for those working in mental health, but for individuals, families, communities across Ireland who are impacted every day by the way that mental health is supported and legislated for in Ireland. So I'll take a little bit of moment to explain about who we are as Mental Health Reform, if you're not aware. We're Ireland's national coalition for mental health. We represent over 80 member organisations in the mental health space. Our mission is simple but vital: to drive progressive reform so that everybody in Ireland has access to mental health support when they need it and where they need it. We advocate for a rights-based, person-centred approach that really is key for us, and that's why we're here today. Because the Mental Health Bill and the reforms proposed within it will directly shape how people experience care and autonomy during mental health difficulties. So for today's webinar, today's lineup, you are definitely in good company this afternoon. We're joined by two outstanding experts in the field who also happen to be my colleagues. They'll guide us through our key issues in the Mental Health Bill, our concerns, hopes and recommendations. So I'm delighted to be able to introduce Dr. Louise Rooney, who's the Policy and Research Manager, and Lisa Marie O'Malley, Policy and Advocacy Coordinator. Together, they'll walk us through what the bill proposes, what it gets right, and where it could be improved. After the presentation, we'll open up the floor for a panel discussion where we'll be joined by Nicola Byrne, who's graciously offered her time today. Nicola is the CEO of Shine and is a long-standing advocate for the rights and dignity of people experiencing mental health difficulties. So it's a great lineup. This is going to be an opportunity for you today. We really want your participation. So at any point, if you want to ask questions, there should be a Q&A button at the foot of your Zoom window. So that is the questions box, and we really encourage your participation. So if you have a question at any time, please pop it in there. We'll be monitoring it. And then in the latter half of our hour session, we will open up the question and answers so we can have a very engaging conversation with the panel discussion. So whether you're experiencing something that you'd like clarified, if you have a concern you want to flag, if you have something from your own lived experience that you want to share and are willing to do so, then this is your opportunity. So without any further delay, I think I've covered most of the housekeeping. I'd like to hand you over to Louise and Lisa Marie for their presentation. Thank you again for joining us. And yeah, let's start the conversation. So over to you, Louise. Thank you.
Thanks a million, Stephen. And thanks again to everybody who's here today. I'm going to fly through this first slide because the important stuff is kind of further down the road. So first, I'm just going to give you a little bit of a timeline and some history about the bill, where it started out, how we got to where we are now. So in 2011, the government announced a full review of the Mental Health Act, and it identified key areas for reform. And this was followed in 2012 by an expert review that began, and it was subsequently published then in 2015. And that review made 165 recommendations. And some of the big themes that came out of that was that it called for a shift from best interests principles towards a rights-based approach. And it also called for better safeguards for people receiving involuntary treatment, which is important as we get further into the webinar. In 2021, then the government approved the Heads of Bill, and it was formally published in 2024. And then this year has been a big year because Minister Butler restored the bill to the second stage. And that was one of the first things that she did as Chief Whip. So that happened at the beginning of the year, and then in May, 241 amendments were submitted to the Cabinet. In June, those proposed amendments were brought to the Dáil floor at committee stage, and they were passed. And then in July, the bill passed report stage and final stage of the Dáil, and it will be moving to Seanad stage after the summer recess. So after quite a long period of time, since since 2011, this all started out. In the last kind of 6 months, it's moved very, very quickly. So that'll tell you how, how important it is for us to move on and look at where we're at. So just very quickly, just a quick overview of the bill, and just to say we'll be sharing the bill where you can access it online, so you can have a look yourself. But as it stands, there's 9 parts and there's 222 sections. But the sections we're going to be talking about today, or the parts even, are the guiding principles, involuntary admissions, and children. So whilst we're talking about, I've said a lot about the concerns, there's also some really positive aspects of this bill. I don't think there's going to take a whole lot to change it, to bring, to make it a really excellent piece of legislation. So the things that we feel are really positive are the guiding principles, and there's a general improvement in person-centered language throughout the bill. There's increased safeguards in relation to physical and mechanical restraint and seclusion. There's a lower age of consent, so to 16 and over, and this puts it then on par with medical and dental treatment. The review period and operation of the Act will happen within 5 years, which means the government are obliged to have a look and see how well the legislation is working. There's a dedicated section for children, which was missing from the 2001 Act. And there's also been an extension of regulatory powers for the Mental Health Commission to oversee community mental health services, which is a brand new thing that will be happening as well. So our points of concern. So Section 48 of the bill allows voluntary treatment to begin before a capacity assessment has been completed. But importantly, it's good to define, well, what is a capacity assessment? A capacity assessment is a structured process used to determine whether an individual has the ability to understand, retain, use, or weigh information about a relevant decision, and to then be able to communicate that decision. So why is it problematic that involuntary treatment can begin before a capacity assessment? So it's imperative that an individual's capacity is clearly established before any involuntary treatment is administered. And that's because without a capacity assessment, there is no way of knowing whether the person has the ability to make their own decisions. And this creates a real risk of administering non-consensual treatment to somebody who, in fact, actually has the right and the capacity to refuse it. So this not only undermines the Assisted Decision-Making and Capacity Act, but it also undermines international human rights obligations and best practice. We're also quite concerned that there is no clear timeline for when a capacity assessment has to take place once involuntary treatment begins. And there's no further requirement on how regularly those capacity assessments should reoccur. Capacity is fluid, it changes. So it's really important that it's assessed on a regular basis to ensure that people's will and preferences with regards to their treatment are being met. So what do we recommend? We're asking that capacity assessment should be completed before a person is involuntary treated. And if in very limited circumstances that can't happen, there should be a short, clear, defined time frame in which a capacity assessment has to happen. And we've given an example there for 72 hours. We'd like to see for it to be mandated for a periodic reassessment of capacity during detention. So that's what I was saying there about reoccurring and reassessing people's capacity to ensure that somebody doesn't now have capacity and has to endure further treatment. Document how the person's will and preferences were identified and respected, or explain why this was not possible. And then the Mental Health Commission should audit all involuntary treatment provided before a capacity assessment is completed. It's really important to have oversight of anything that's happening before a formal capacity assessment is happening. So Section 48 of the bill also broadens the criteria for involuntary treatment to include circumstances where a psychiatrist believes treatment is immediately required and the suggested treatment would be likely to benefit the person's condition. So it's the likely to benefit that we find problematic. So if we peel away the legislative language here and think about what that actually means, it's allowing for the forceful treatment of somebody if the psychiatrist believes that treatment may help. That's in very basic terms. So if we consider the nature of treatment, it's generally assumed that any intervention offered would be intended to benefit or help the person who that treatment is being prescribed to. So using a criteria like likely to benefit as a reason for involuntarily treating somebody is simply too broad, as it would apply to almost anything, because it would apply to anything that it would be totally dependent on the clinician's opinion. And that's just too much discretion. We need the legislation to be tighter. So what are we calling for? We suggest replacing the term likely to benefit with more precise language to limit involuntary treatment to urgent cases only, where the delay or absence would seriously endanger the individual's health or safety. We'd also like a clear pathway for individuals to challenge treatment decisions once a person has regained capacity. You should be able to challenge and ask questions about your involuntary treatment, or in fact, any treatment that you're given. And finally, we'd recommend that the Mental Health Commission establish procedures for an independent audit and to review involuntary treatment decisions to ensure accountability and safeguard people's rights. So I'm going to pass over now to Lisa Marie, and she's going to talk you through a couple more concerns that we have. So thanks very much.
Great stuff. Thanks, Louise, and thanks everyone for joining us today. So I'm just going to continue on speaking a little bit more about involuntary treatment, and I suppose it is just worth, really highlighting the fact that these concerns that we have about involuntary treatment all come from recent government amendments. So the 2024 version of the bill was considerably tighter in terms of involuntary treatment, and these recent government amendments have significantly broadened it, and the ones I'm going to speak to now are further examples of that. So another one of our concerns in relation to involuntary treatment is the fact that the time frame for involuntary treatment can now be doubled from what was 21 days in the 2024 version of the bill to now 42 days. And even more troublingly on that front, while the previous version of the bill had said that an application to the Circuit Court for decision support must be made before any involuntary treatment is begun, now that application just needs to happen at some point within the 42-day window. And after that application has been made, involuntary treatment can continue beyond the 42-day window until the Circuit Court makes its decision. And I suppose when we just think about what that means in reality, potentially that application to the Circuit Court could go on the 42nd day. Then the person risks, waiting through what can be quite a long list in terms of the application to the Circuit Court and waiting for that to be heard. And all that time they're being subjected to involuntary treatment without any decision support. And the without decision support is particularly concerning on that front. So from our perspective, in terms of recommendations, we would say that we would want that involuntary treatment window reduced back to 21 days. We also believe, and Louise has articulated already why it's so important, that there's continued capacity assessments made throughout that period to make sure, to acknowledge the reality that capacity is fluid. And we would also say that applications to the Circuit Court for the decision support should be certainly made within a timely manner, and we would be saying at a minimum kind of 72-hour window for that application to be made. And if you can jump to the next slide. Thank you. So another section that we would be concerned about, and it wasn't something that we had flagged in our original paper, but it is something, so we are updating that paper and publishing it, and it is something that's going to come up in that, is around section 51. And again, recent government amendments on this front are quite concerning. So what this section now states is that if a person has been involuntarily detained and a psychiatrist believes that they are likely to benefit from treatment, even if that person has capacity, and capacity that is under the Assisted Decision Making Capacity Act, which, as Louise said, means they understand the decision, can weigh it up, and can clearly communicate their decision, even in those circumstances, or even if they have an advanced healthcare directive saying they don't want that treatment, or if they have decision support saying that they do not want that treatment. An application can be made to the High Court for them to have that treatment. And there's a 72-hour window there in which the person can be treated until the High Court hearing is heard. So that particular part is one that we would have significant concerns about, and that was the one that was changed. The fact that now treatment can actually be given before the High Court decision is even made. And that 72-hour window, when we think again about what that means, potentially you're going to have a person be given mind-altering medications within that treatment, within that period, and then expected to go through a High Court process where, you know, they're going to be significantly compromised in terms of being able to actually articulate what their wills and preferences actually are. So we would have, as I said, considerable concerns about that. I would also just note on this section too, that it does state that if a person finds themselves then accepting the treatment, the application to the High Court will be revoked. And we would again highlight a concern there around potentially coerced consent and what that could mean. And we would say that in any circumstance in which a person has capacity and has stated that they do not want treatment and it has been forcibly given to them, that the High Court really should be reviewing those cases to see what exactly is going on there. So in terms of our recommendations, again, we would say that no person with capacity, in line with what the 2024 bill had said, no person with capacity should be involuntarily treated before a High Court ruling. That would bring us in line with physical health treatments as well. And at a very minimum, we would say that those treatments should only ever be provided in absolute emergency circumstances. We also believe that there must be a very stringent review process if a psychiatrist is overriding the clearly expressed wishes of someone with capacity or with an advanced healthcare directive or decision support. And we would also say, as I said previously, that it should be going to the High Court for review, and that also all legal and procedural supports that are going to be offered to those people in those circumstances need to be very clearly articulated for people. And I'm just going to touch now on some of our kind of more long-standing concerns with the bill. So the involuntary treatment section mainly focused on government amendments. But what we are seeing, what we continue to raise concerns about is the fact that there still is an absence of an independent complaints process and a statutory right to independent advocacy. And from our perspective, you know, these two measures are absolutely essential, and in particular in the context of, you know, the revised criteria on involuntary treatment, they become all the more important. We also see that although, and Louise mentioned it, there is a section on restrictive practices, which includes welcome safeguards around physical mechanical restraint and around seclusion. There's no such section around safeguard and chemical restraint. So we would say that definitely needs to be safeguarded within the bill. And even still, of course, you know, the UNCRPD is calling for the abolition of restrictive practices entirely. That's a step past where we are, but at the very minimum, we would say that there needs to be safeguards in place around chemical restraint. And just, I suppose, for clarity's sake, because you know it's a complicated term, chemical restraint essentially boils down to the potential misuse or overuse of sedatives in the mental health care setting, and you know is deeply problematic. So it is something that we would believe needs to be safeguarded. Another point of concern for us is the fact that the bill continues to allow for the admission of children to adult units. So it is worth noting that you know, the numbers on this have gone down in recent years. We certainly acknowledge that fact. From our perspective, though, without any legislation explicitly prohibiting that, you know, there's no safeguarding in place to stop those numbers from rising again in the future. It's great to see them down at the moment, but that doesn't mean it will continue to be the case. And it's utterly unacceptable, really, for children to be being treated in age-inappropriate environments. And at a very minimum, we would say that if there's, circumstances where it must happen that a child, for whatever reason has to be in the adult unit, that should be for a very, very clear time period, very short. And after that, they should be being transferred to a more age appropriate setting. And again, obviously that should only be in very exceptional circumstances. So we gave an example there of a 72-day window just to account for, weekends and things like that, where staffing could be an issue. We've also seen in the bill, although the language generally has improved, and Louise mentioned that previously, there's the continued use of the term mental disorder. And that is, that is deeply inappropriate at this point in 2025. It's widely agreed by people with lived experience that the term is stigmatizing. And, it is important to note that language matters, language shapes reality. And so it's really, really important that the bill reflects that, and changes are made on that front to really get rid of that very outdated terminology. And we would be saying replace it with the likes of mental health difficulties, as mentioned during the vision, or else psychosocial disability in line with the UN CRPD. And just a final point of note is the fact, and this is really more of something that needs to be clarified. Currently within the guiding principles of the bill, it states that the will and preferences of parents and guardians of children over 16 must be recorded and given due weight. So on the one hand, it says that 16-year-olds, 16 and above, should be able to make decisions in relation to their treatment, and that is of course in line with physical health treatment. But on the other hand, it's saying that this due weight should be accorded to parents and guardians. So I suppose from our perspective, it's just a case of clarifying what exactly that means, and ultimately, who gets final decision-making authority. So that's not currently clear, and we think that needs to be clarified. And in terms of physical health, parity with physical health, obviously people 16 and over in physical health make decisions around their treatment. And this is just basically, so we had a meeting with stakeholders recently where we discussed some concerns, and this is just really a visual representation of some of the main things that came up from them there. And I think that's it on my side. I don't know if I'll hand back over to Louise to talk through the next steps.
Thanks very much, Lisa Marie. I suppose just very quickly, because I'm eager to get Nicola in here, just to talk about what our next steps are in terms of what our mental health reform going to do next. So we have updated the recommendations and concerns paper, and that's available from today. We'll send out the link in the chat so that you can access that. And that just gives basically a more detailed account of everything we've said here today. We've written a letter to the Seanad outlining our issues, and that is going to go tomorrow. And we're trying to set up our any kind of lobbying and advocacy that we're going to be doing when the Seanad come back after summer recess. And then that's where we will find ourselves in September, is that we need to make all of the senators aware of of our issues and see can we make the changes to the bill that we need. And that's where people like yourselves come in. And if you're so inclined, we would greatly appreciate anybody reaching out to senators, or just spreading the word amongst yourselves. It's really important. This is our last real chance to get the bill to where we want to go. And here we are. These are just our resources. Stephen is going to share them in the chat. So the bill is there, so you can read through the bill. The bill is initiated, the bill that has passed, and then our concerns and recommendations paper. And hopefully you'll find those of use. You can join our newsletter, where we have updates every month. And thank you very much. And our slides will be online. You'll be able to access them there as well. And that's it. So I'll stop sharing and we can get Nicola in for a bit of a chat.
Great. Thank you so much, Louise and Lisa Marie, for that presentation. To Louise's point, the slides presentation will be available on our mental health reform plus a website plus a recording of today's session as well. So the resources will be there for you to review. I just want to thank you all so much for the questions that have been coming in, and it's really getting an idea of like the temperature of the room, which is great to see. So we'll be looking forward to deep diving into those questions afterwards. Firstly, I think I need to introduce Nicola and to thank her again for her participation today. Nicola, as the CEO for Shine, this is clearly something that is very close to your heart and that you've been following closely. I guess the first question I would ask for the people that Shine serve, what has been their experience of involuntary treatment and assessment? And to further that, like if they were holding the pen, how would they co-create the legislation? What would they see as important?
Thanks for that question, Stephen. You can hear me okay, can you?
Yeah, loud and clear. Yeah,
Great,
thank you.
grand. Okay. So I suppose in Shine's an organization that's been going for nearly 50 years, and we work alongside people who've experienced mental health challenges, including those who've been subjected to involuntary detention and treatment under the Mental Health Act. Their stories, shared with honesty and vulnerability, often reflect a deep sense of fear, disempowerment, and exclusion, and many describe their experiences as something that happened to them rather than with them. It's a process where their voice, their autonomy, and their rights are often lost in the system. And people have told us they felt invisible in decisions about their care, even when they were in need of compassion and support. And that family members and supporters too often describe being shut out of the process, left without information or involvement, despite being central to the person's life and recovery. This lack of communication can compound distress and lead to long-term mistrust in services. However, these same individuals also highlight what makes a difference. That is being treated with dignity, being listened to, having choices, and being informed about what is happening and why. Where services and staff took a human rights-based approach, even during a crisis or detention, the impact was markedly more positive. I suppose when we talk about shaping mental health law and policies, these voices must be at the centre. We must learn from their experience and build a legal and service framework that prioritises rights, transparency, and relational care. And this includes things like ensuring real mechanisms for supported decision making, embedding the principle of least restrictive care, promoting accountability and oversight in how voluntary powers are used, and investing in early intervention and community-based supports that reduce the need for detention in the first place. Ultimately, we need to move from a system that reacts to crisis with coercion and to one that supports recovery through partnership and human connection. And it's really important, most days of the week we receive calls from people that want help, they want support, and often they hit the stage where most of this legislation should be irrelevant to most people, in that if we act early enough, these situations shouldn't arrive. I think for people who use our services, they don't want blue lights at the door. Currently, it's very hard to get information. It's even more difficult to access GPs. So I know in talking about the changes that need to happen and maybe the issues with the amendments and concerns, there's other stuff that's very welcome, as well as issues that are of concern at the moment. But at the end of the day, we can make it right by actually thinking about if what is to happen to us, what would we want? I wouldn't want to be waiting 42 days. I wouldn't want to be operating in a void. I wouldn't want to not have access to a clear an advocate that would be able to support me. And a lot of these problems can be addressed if we continue to work towards legislation for what is right, that what is needed, that aligns with what the government said, that they would meet human rights conditions and the UN CRPD. If we do what's right, it's very easy to make this good, rather than thinking about, well, the courts won't be able to meet the time frames, so therefore we need to change the legislation, or we don't have a CAMHS inpatient unit in the Midlands. And so I know from having worked in the Midlands myself that if I was a young person aged 17, I'd rather be admitted to a inpatient unit up the road from mum and dad you know, and have them come and visit me, then they have to trek up into Dental and Dara and maybe get childcare for their other siblings. So what I'm saying is we need to legislate for what is right and good and, you know, meets principles and what we've signed up to, rather than the practicalities of underinvestment for decades in our mental health system. This is, you know, there's been money put in year on year in recent years, but it started from a low base. So I think our service users are really saying that, you know, they don't want to be in the situation where they need to be involuntary admitted. They don't want to have to go there. And when they do go there, it needs to be what is right and fair and good.
Yeah. Thank you so much. And you know, when you're just speaking about like the human rights element, there are 107 attendees here and 7 panelists, and I just maybe implore you just to empathize there when Lisa Marie was talking about Section 51 and 72 hours. Like, it's not just a number. Like, I was just picturing myself like 3 days without counsel, without a voice, not knowing what's going to happen next, having those basic liberties being taken away for 3 long days. You know, it's I think we have to think emotively about this and the impact, the real impact it would have on people. So thanks for highlighting that, Nicola. And when you mention your service users, are they aware of the changes that are proposed that are coming down the line?
I suppose that's a really important question, Stephen, because from our engagement with people who use mental health services, it's clear that awareness of the bill is still quite low, and it's low for those that probably would be most affected by it. While some individuals with lived experience are actively involved in advocacy and are well informed about the proposed changes, many others are unaware that reform is even underway. So there's a real gap in communication and consultation, and for too many, mental health legislation feels like something that happens around them rather than with them. And that really does need to change. When we do discuss the bill with people supported by the likes of our service, their reaction is often one of cautious hope. They welcome the idea of stronger rights protections, greater transparency, and increased involvement in decisions about their own care. But they also express skepticism. You know, it's been shaped by years of marginalisation and in some cases really distressing experiences within the system. And we used those testimonies when we were in front of the Dáil subcommittee on the mental health bill. And, you know, it really does bring to light the difficulties and challenges that can happen. Because even in the current Mental Health Act, there was a shape for authorised officers to be invested in and for third parties to be able to, and you know, there was a small amount of authorised officers trained and developed in Ireland, but it was never fully invested in. And to this day, it's very hard to get somebody admitted when somebody is actually really concerned about themselves or about the risk to others. And, you know, so investment is probably key to all of this work. So communications is important, but people wanted reassurances that reform will be more than words on paper. They want to see real changes in how services treat them, particularly when they're in a crisis. They want clear information about their rights, accessible supports to exercise those rights, and accountability when those rights are not upheld. It's really important that the government and services, you know, make the effort and step up to engage directly with people who use the mental health services. And a great example of that is, you know, the work that's going on with putting the voice of lived experience at the centre of policy development, implementation and sharing the vision, the likes of the reference group that we host. And we can see a real change in people's understanding about, you know, it's not othering. You know, any of us in the room can end up needing to be involuntary admitted in the morning. And it's really, I just think if you keep that at the centre of it, you know, I'm a health and social care professional, but I'm a registered social worker by background. But at the end of the day, tomorrow I could be an inpatient in a psychiatric unit. And it's really key that this reform has to be meaningful. It must be rooted in the voices and the experience of the people it's designed to protect, you know?
Yeah. Thank you so much. Lisa Marie, I wonder if I could bring you in on this maybe similar topic when if we were to look at the importance of advocacy supports and a clear complaints process. You touched upon that before in the presentation. Could you expand on that? And what would be the risks if they're simply not there?
How much time do you have, Stephen? No, I'm joking. But yeah, no, it's definitely something that that I feel very, very strongly about, the absolute need for those. So I suppose when we talk about an independent advocate first, just to be very clear about what we're saying a person that can, you know, support a person to ensure that their voice is being heard, to ensure that their rights are being also explained to them, which is really, really important, and to make sure that their preferences are being clearly articulated. And again, I think Nicola spoke so well there and so movingly about, you know, how terrifying that situation can be for people. And, you know, there may be, and I'm sure there are different views on the call in terms of the need for involuntary detention and the need for involuntary treatment and things like that. But I think very, very few people would argue against the need for safeguards in those circumstances. And then, and, you know, would think to themselves, if I was in that circumstance, what would I want? Would I want to have someone there who is on my side, who is there independent from all else, who is there to support me through this terrifying process where I suddenly find myself, you know, locked up. I'm also, you know, experiencing mental health difficulties, and I'm also receiving, you know, potentially, you know, mild mind-altering medications that I may or may not want. Absolutely, in those circumstances, it is essential that someone has that independent advocate with them. And of course, I would, and mental health reform would say that an independent advocate is really, really important and essential for all people accessing mental health services, but in particular for this particularly vulnerable cohort who are, you know, involuntarily detained and involuntarily treated. And then just to touch on the independent complaints mechanism, I actually think I saw a question briefly at the corner of my eye in relation to that. Yeah, I noticed that people were asking about HSE, your service, your say. And we would be saying that it would need to be separate from that, absolutely. Again, if you just think about the circumstances in which people find themselves, you know, you don't want a person who is already, you know, facing a very, very significant power differential. And that is just the reality. When you're in that circumstance, in particular of involuntary detention, everyone else essentially holds the power over you. You do not want to then have to complain to the service about the service. That is not acceptable. It's not okay to be, you know, asking or complaining to a colleague about a colleague. So we would absolutely say that it needs to be entirely independent of that. And, you know, currently the Mental Health Commission, you know, are there, but they do not investigate individual complaints, and that is a real problem. And it's worth just noting as well that, you know, we do have the tribunal process, which is going to be, you know, the review board process based on the bill, but that only looks at involuntary detention decisions. It makes no commentary, or it doesn't look at all at, you know, for example, the likes of involuntary treatment and that whole process and what has happened there. So someone could have a very legitimate grievance about what occurred for them there. And it really is important that there's an independent avenue for them to seek recourse in those cases. And I'll stop there because I could keep going forever.
Thank you. You can take a breath now. It's okay. Thank you so much. It's so much to go through, and even it's quite overwhelming, you know, 222 sections, I think. So just for yourself and Louise to be able to break it down it's great and very eye-opening for everybody here. I'm going to move the conversation along. The questions are coming in thick and fast, which is fantastic. I might ask Louise for her thoughts on you know, how can we activate a campaign, and what would you see as the main challenges in ensuring that the proposed changes are given serious consideration by the Shannon, who we've been in contact with recently?
I think I've just saw the questions coming in there, and a lot of people are saying, you know, how quickly this process all happened. You know, we over 200 amendments. It went to committee stage very quickly. Within a number of weeks, we were back at report stage. So we found ourselves, you know, unable to keep up. To really, we're not legislators, we're not barristers. So to be able to get through the bill and really understand what it means, to then critique it and see, you know, well, how do we align this? If we had a magic wand and we could make this totally based on human rights, how would we do that? So it took a lot of time, and that's why we've had to update our concerns paper, because we're still finding things that we think, oh, you know, changes need to happen here, there, and everywhere. So I think that's been a real challenge, and I think that is going to be an ongoing issue as we move through to the Shannon. because it's very hard to articulate everything that we want to say, and in a way that people understand and digest it and feel that what we're saying is valid. You know, and I'm not being derogatory when I say understand and digest it. I still, every day, every time I look at the bill, I understand it a bit differently. So to present senators with really dense legislation and, you know, really dense amendments and reasoning for, you know, why we want the changes is a really huge task. So I suppose what we would love is for people to contact their senators, to contact local TDs, to put the pressure on if they can, if that's something that they feel they're happy to do, to talk about it. Because I think the rhetoric has been very low and very damp in regards to it. There's just it hasn't hit the headlines. It's not in, you know, we're just not talking about it. And before we know it, the bill is going to be in, and we're not going to have a chance to get us to where we want it to be. And that's the other thing, is that some really, really targeted amendments can bring this bill, you know, so far forward. It's not going to take a lot of work. There's a lot of good in this bill. So we just really hope that the Seanad are responsive to us. I hope that answers your question. I kind of took off there.
Thank you. Thank you. Great improv. And you mentioned hope twice. I think that's how I'd like to conclude the panel discussion part of today. Like we've mentioned a lot of issues, concerns, but like we are an organization of hope as well. And Nicola, maybe I'd ask you for the last soundbite. Like there are positive aspects of this bill, and what would you see as hope for improving mental health in Ireland if you had the magic wand?
Okay, I think I'm around a long time working in mental health and advocating for improvements and change. There's a lot to be welcomed about this bill. And I remember advocating for the last bill, which took way longer to turn into an act than this one. So at least we're moving forward. So, you know, at present, we have a situation where we're introducing a piece of legislation that mostly is aligned with the UN CRB, the UN Convention on the Rights of People with Disability. There is a couple of glitches in it that do need to be fixed, and people need to advocate on those issues. But when we look at it, we're looking at a process of modernisation, a rights-based approach, that we have human rights principles and international best practice mostly embedded in this new bill. We are experiencing a fundamental shift from a more custodial approach to one centred on individual rights and self-determination. The bill is also an important amendment to review the Act every 5 years rather than 10. That's a big step forward, because God knows a lot can happen in 5 years, and a decade just seems like a lifetime away these days. You know, in the guiding principles for care, the bill incorporates guiding principles for both adults and children that mandate presumption of capacity, respect for dignity, bodily integrity, privacy and autonomy. These are all important principles. The best interest and welfare of the child should be a primary consideration. Even the fact that CAMHS is now coming in under the legislation is really, really helpful. The introduction of a nominated person for both adults and children is a positive step forward. And that allows you to designate someone to receive information and consult on care and treatment decisions. The bill has a section dedicated to legal aid, which outlines the establishment of a panel of legal reps. And this ensures that individuals have access to free legal support without reference to their financial resources. There's a focus on care planning and psychosocial assessment, and the bill requires comprehensive care plans. Really, really welcome for someone who's worked a long time in mental health services, both in statutory and the voluntary sector. For the involuntary admitted person, a psychosocial assessment must be carried out by a mental health care professional other than a consultant psychiatrist. And that's really, really helpful, because we need to remember that mental health and mental illness is impacted by all of the other factors in society: our family of origin, adverse childhood experiences, poverty, housing situations. All of those factors need to be taken into account when we're making assessments about people's treatment and support. Also, the issue around regulation and oversight of services, that the bill provides for the establishment and maintenance of registers. There's a lot of positive work. The work has been going on this really weighty document for over a decade. And so often there's stuff that we are concerned about. Mental health reform is concerned about, the members are concerned about, the public are concerned about, people who use our services are concerned about. But there's a lot of positive aspects to the progress that's been made. And I suppose hope is important, but also to ask people, this is about everybody's liberty and everybody's welfare. And so there's aspects of this current bill that need to be improved on. And so to get active on addressing those issues.
Yeah, thank you so much, Nicola, and all of you. Like, given the size of the bill, like our presentation today was relatively short. Like, to Louise's point, there's a few amendments that need to be looked at, and advocacy is why we're all in this game as well. So I think it's nice to end it on that call to action. Personally, I'd love all of our attendees just to cancel their next meeting, and we could take our time with this panel discussion, because everybody has been providing some great questions and just a lot of curiosity about the presentation and the bill. Unfortunately, time is against us, so we'll go through them as quickly as possible. And Louise, Lisa Marie, and Nicola, you may have your thoughts on this. Maybe in no particular order, but a simple question to start. Does the Act specify exactly what they mean by treatment? Is it just medications? Or could it be, well, I'm presuming I'm adding like therapeutic interventions potentially?
Yeah, so the bill, or when it says treatment, it does include therapeutic interventions as well. So it gives a clear definition at the start in terms of what constitutes treatment. I guess from our perspective, ultimately the decision is being made by consultant psychiatrists in terms of, we'll say, involuntary treatment. So that would need to be recognized in terms of, obviously, psychiatry, what kind of treatments they would be more likely to provide.
Thank you. And another very simple, straightforward, important question to ask is, where did these changes come from? So the bill that we had been advocating was maybe not spotless, but it was looking a lot more different to the one we're presented with today. Who in the government made the changes to the bill? It seems very archaic and very worrying, says one of our attendees.
I might come in on that one. I mean, the simple answer is we can't know for sure where they came from. But when we have inquired with the Minister's office, we've been told that it's stakeholder engagement. And obviously we're not privy to who those stakeholders are. Mental health reform, along with the Irish Medical Association and the guards were called into committee stage to give a statement and to express concerns, and that happened in June. But most of these decisions were made prior to those statements being given and to us being asked. Stakeholder interviews and consultations have been happening throughout, and I suppose that's a question for the minister. It's something that we've been asking, but it's not something that's clear. So sorry, I can't give a better answer on that.
Okay. Thanks, Louise. Thank you. We had a message from Owen, more of an observation that the regulatory authorities, mental health services, should be attempting to get away from chronically drug-dependent services. He highlights newer forms of treatment such as open dialogue, soteria houses, Trieste models, where chemical restraint is not the first line of treatment, relevant to people experiencing psychosis, but also in other areas. The regulatory authorities and mental health services are brought into big pharma concerns. Drugs are not always necessary or to the extent that they are used today. So I think Owen speaks to maybe an over-reliance or familiarity with just drugs first to medicate. I think it's more of an observation, but thank you, Owen. Emma's asking, in terms of an independent complaints process, does mental health reform see this as being different procedure from the Your Service, Your Say pathway? I think, Lisa Marie, you spotted it out of the corner of your eye. Or is it better, to, in your opinion, to develop a new one specifically for mental health that is independent? I think Lisa Marie's covered that already, but maybe if you want to add a final note.
Yeah, no, I think absolutely that it should be separate. I think that's essential.
Okay, thank you. Thanks very much for the question. Looking again, and more are coming through our webinar chat function as well, so my eyes are going cross-eyed now. So how do we handle or capture the mental health situation of children who are in a family with toxic relationships and domestic violences? Is that...
I think that's a question for Nicola with the social work background. Just throw you in there.
Thanks. Well, actually, there's a new policy within the HSE family, Think Family First, that social workers and other disciplines have been very involved in developing, and that's live. So it's really important that even if, say, our service, we don't work with children, but we would always be aware that people, you know, may have children, and that you need to bear that in mind when you're working with. Being a parent, like, is a very stressful thing, and it's important to really be mindful of the issues that arise when we're all, you know, when we're in the parenting role, and you know, the impact of that. You know, there is people should never be seen as an individual in isolation, that there is a network around them, and that includes children. So it's important to bear those factors. And I hope I answered it, because I was, yeah. But do if you're working in health and social care services in the HSE, please be aware of that policy. Thanks.
And I think it
Thanks very
goes back
much.
to as well, Nicola, you know, that cross section, you know, mental health, it's cross sectional,
Yeah.
and it doesn't happen in isolation. It happens alongside domestic abuse, addiction, all of those other things. So it's taking that holistic view, and I think that's what that family first policy does, is that, you know, this is not just the hate, you know, this is not just the Department of Health, this is justice, this is Department of Children and Equality, this is, you know, there has to be a full repertoire of wraparound supports, particularly where there's children involved.
Yeah, I may have got the name of that policy wrong. I just see somebody's tried to, I'll put it in the link when I get a second, because it's a relatively new policy. But it is about the fact that, you know, we are in a system, and we need to bear all of these factors in mind. But it is really important to be aware of children are in, you know, they're around all of us in different ways, whether it's as an aunt or a mother, or and the, you know, with CAN services coming in as well, it's a really important issue.
Thank you very much.
Just jump in there as well, just to say I think that also brings back Owen's point really well about, you know, the need to move away from, you know, solely focusing on the biomedical model, to also, you know, consider all of the other supports that are needed in those circumstances, and to look for, you know, other interventions rather than just immediately going towards the biomedical model. But that might be a conversation to get into another day. But
For another webinar. Okay, thank you. I think we have a comment here from Tara, and to say that access to advocacy services, and indeed different supports and disciplines within services, seems to be very hit and miss around the country. How do we improve the geographical disparity in access to equal services across all disciplines? Is this highlighted in the concerns paper?
it is definitely a concern that we're aware of. I would say our PBS, not to be you know, doing a plug for that, but that is one of the main things in terms of accessibility, was something that came up repeatedly in survey responses. So it goes across the range of services. It's certainly not just to advocacy, but it is something that we totally recognise is an issue. And again, we just think if there is legislation in place, you know, and like statutory footing for independent advocacy, you know, it will force, resourcing off advocates and things like that. That would be certainly what we would be envisaging and what we would be hoping for, because right now those services are massively underfunded. And I also, just again, seeing out the corner of my eye, but I noticed that someone had said about, whether the assumption that a mental health advocate is always helpful would stand up. And, I'm not here certainly to say that, I'm not going to contradict any person who's had a negative experience with advocacy. Obviously, it can never hold up in all cases. And certainly it would never be a situation that that we would be saying that it should be imposed upon any person. It should be obviously an opt-out, or there should be an opt-out option for any person that doesn't want to engage, but they also, we firmly believe, should have that right to access it given the circumstances that they are in. And I would just also note that, the UK or Scotland, England and Wales all have that right. So it is just something that we are behind on.
Thank you. I think that word assumption is something that had been featured quite a few questions. Cara had noted about the situation where a person who had no supports, especially at the weekends, that they could be waiting for a decision from a judge who knows nothing about mental health. Or worse, they may have their own opinion on mental health as well. And the assumption that a mental health advocate will be able to perform all the time, assumption that the law will have a fair understanding of a person's rights as well. And I guess we have to do this and navigate this in faith that the law that is put forward is followed by all.
Can I just jump in there, Steve?
Yeah.
I just wanted to highlight there that what Cara's saying there is so important, and it highlights how vital it is that there is no room for discretion, that nobody is going to read this bill and say, I don't really know what that means. So when you give discretion to a clinician or too much discretion to the judiciary, then that's when cognitive shorthands come in, and we make decisions based on prejudice and bias. If we don't have too much room to move, then you only have the legislation to guide you. Obviously, there's always some element of discretion, but then layered on top of that, there's always also human rights principles. So that is a huge part of why we are trying to advocate for tightening on these amendments, and why we're saying that there's not that, it's not that much work to do. It's changing a few key words to tightening up so that nothing can be left open to interpretation. Because whether it's discretion and interpretation, there's room for things to go wrong.
Thanks very much for that, Louise. I think we'll be coming to the end of our discussion. We'll just try and squeeze a couple of observations in. Hannah wanted to know, were there any service user stakeholders with experience of involuntary detention at the committee stage meetings? Louise nods head.
No, we had we have a grassroots forum, and we work with people with lived experience, and of course our members do as well. Like Nicola's, she's CEO of Shine, and they have a huge lived experience panel. So we would have been informed in our asks at the committee stage by people on the ground, from our members, from the people who work with people with lived experience, who are accessing services every day. But at committee stage, no, there was nobody with lived experience directly representing people with mental health difficulties. So that's the simple answer.
Yeah, and I just to come in on that point very quickly, I suppose it's worth noting that the bill was actually brought to the Dáil floor rather than going through the normal committee stage process. So under the normal committee stage process, well, given that there's no current subcommittee on mental health, it would be the health committee that would typically, review the amendments and review things like that. This time it was actually brought directly to the Dáil floor. So that meant that the kind of expert like testimonies or commentaries on the bill, and certainly obviously one of the most important testimony, of course, would be those with lived experience. They just didn't get that same opportunity that you would normally see. So that's just worth noting.
Thanks for adding that, Lisa Marie. I think unfortunately be coming to the end of this webinar, and thank you everybody for the questions that have been posted and the insights and the lived experience that really enriches it, to see past statistics. So I'm grateful for that. Had some thoughts there from the comments that lead me to wrap up, where we have a summary of our concerns and recommendations on our website, mentalhealthreform.ie. There's a dedicated page there on Reform the Mental Health Act. So the concerns and recommendations, the presentation that has been given today will be available online. We had a great idea from Owen, if there is a letter, like a templated letter, if I can understand it correctly, where we can outline these concerns that people, the general public, could take them and give them to the representatives. So that's something we can definitely do, and we can have that up online in the coming days to make it easier. So I think, through the years, it's been a relatively slow process getting to this point, and now the pace has well and truly picked up in the last recent months. So I think it's very easy to be overwhelmed by the pace and possibly the lack of communication. So to that end, I'd recommend that you visit our website, mentalhealthreform.ie, where our recent concerns, as of yesterday, have been posted online, and as new developments come in, they'll be reflected there, and also to subscribe to our newsletter to keep ahead of this. So with that, I'll offer the mic back to our panelists today, if you have any closing remarks.
No, I don't think so. I just, I wanted to thank Nicola. She's a very busy lady, and it's fabulous to have her come on and share her knowledge. It's been great. And thanks again to Lisa Marie, who's the resident expert in the bill. And thanks for everyone for coming. We've had a great audience today, and thanks very much.
Thank you.
Okay, thank you very much. So last words, mentalhealthreform.ie. I've been Stephen, and wish you all a very peaceful rest of the day. Thank you very much. Thank you.
Hi, everybody.
Bye.